Hi everyone, I'm Susan Birch and welcome back to another A Health Detective podcast. It gives me great pleasure today to be talking with Dr. Ian Lake about type 1 diabetes. Dr. Lake is a GP in the UK and he's also had type 1 diabetes for 28 years, and he's found a great way to manage it through the ketogenic diet, which he's been using for 8 years. And now he's absolutely passionate about sharing how easy this is. We were just talking beforehand about how scary type 1 can be. And he assures me this is a very easy condition to manage with the right dietary interventions. So Dr. Lake, thanks so much for coming along. Thrilled.
Thank you. Hi, nice to meet you. And it's the actual anniversary of my diabetes. I just remembered today.
Oh, that's
28 years today. I was diagnosed.
Wow.
Yeah. Okay. Yeah.
Well, would you like to start by telling us a little bit about your own diagnosis and your own journey, and then we can sort of get into some questions?
Yeah, my own diagnosis was a classic type 1, really, raging thirst and peeing all the time over a period of about 3 hours. It came on that quickly. But heading into it, I think I had periods where my blood glucose was probably, my pancreas was probably faltering because my blood glucose was probably going up. And I obviously wasn't measuring it because I wasn't diagnosed, so why have a glucose meter? I'm feeling very tired, just generally lethargic, tired, for probably a couple of months out. So I was probably having intermittent pancreatic function, which finally failed on the day. So a raging thirst and peeing everywhere, just for every 10 minutes, massive polyuria. So the diagnosis wasn't really that difficult to make, even for a GP. Yes. So I made my diagnosis, turned myself in, and then, went straight on to diabetes management in the good old way, insulin, managing your carbs and your glucose, managing your carb intake, your insulin injections, and trying to keep your glucose levels stable. And I did that for 20 years with patchy success, really. I was never very good at it, and that's the trouble. And of course, the general vibe amongst type 1s, really, if you're not good at it, it's your fault, because other people can do it, and they can do it very, very well indeed. 8% of type 1s in England and Wales, which is where I come from, get their HbA1c, their measure of long-term diabetes control, into the very low end of the target range. But the rest of us can't do that. And at the current time, which is a relief to me in some ways, for the old way I was managing it, but it's horrific figures, that 70% of people with type 1 diabetes in England and Wales are losing 100 days of life every year as a result of their diabetes control level. Wow. That's based around a study from the European Association for the Study of Diabetes. It was in 2020. So that's a terrible figure, but it puts you into the mindset that, well, perhaps it's actually not our fault. It's just difficult to manage it in that way. Yeah.
Well, there's a few things there. One would be, why did you become a type 1 diabetic in the first place? So, what's the underlying causes there? And I guess there's a lot of different ones for different people. But we are seeing a lot more adult onset now, which I think is interesting. And then what makes managing it so difficult, that balance between that insulin and glucose?
Yeah, there are many theories as to why you get this autoimmune disease called type 1 diabetes. And it is considered an autoimmune disease, although there are a small population of people who are diagnosed with type 1 children who have no autoantibodies. So I think there are lots of ways of getting to become a type 1. You have to have antibodies to have the standard type 1 diagnosis. So autoantibodies to various elements of the pancreas or the nervous system that releases the insulin. And nobody's quite sure how they develop. I think the gut is the leader now for the cause of autoantibodies. And of course, the gut's everywhere. The microbiome is the only thing that causes every disease possible now, isn't it? But I think that's a possibility. But milk is implicated. The sort of casein A1 in milk, one of the proteins in milk, low vitamin D status is implicated. Viruses are implicated, and there's some good evidence that viruses are found in people with what you call fulminant viral infections that set off type 1 diabetes, and often fatal. I don't know how much that plays a role in autoimmunity, but we have to suspect viruses as well. So lots of theories as to why people become type 1. And obviously type 1 is caused by loss of the cells of the pancreas that produce insulin, the beta cells, the islet cells. And insulin is the key hormone that responds to raising of blood glucose levels, either through the diet or through the body making its own glucose for functions it requires. And then if you don't have insulin, your blood glucose goes up rapidly, and you can't control it because there's nothing to bring it down. Insulin is one of the very few, well, it's the only hormone really that brings it down. There it is signaled by other hormones to act, but it's the only hormone really that brings glucose down effectively. So if you've got no insulin, you have to inject it, and you have to inject it into the skin. You can use a nasal inhaler, although they're quite rare at the moment. So 99.9% of people inject under the skin, which is different, of course, to the way the pancreas works, but it does work, and it keeps us alive for 30, 40, 50 years. The first person who was injected in the 1920s lasted about 10 years, which is incredible when you think about that. And the biggest risk was the purification of insulin, which used to cause horrendous abscesses in the body. So it keeps us alive, and you can't do without it. The bone of contention for me really is the best way to manage it. And my own view that has evolved really is that the best way to manage a situation where your body can't produce insulin is to try to recreate those situations physiologically in your life where you don't need much insulin in the first place. You're always going to need it. I'm not saying people with type 1 will come off insulin, they won't. But there are times in our physiology when the body needs very little insulin. And I think if we can create those conditions in our own bodies, which are not difficult to do, we can make life very much easier for ourselves. And that's what I've chosen to do over the past 8 years of keto diet.
Well, we'll get into talking about that.
Yeah.
Just a question, do all type 1 diabetics make no insulin, or can you make a range of insulin but just insufficient amounts?
Yeah, I think you're right. Yes, I think there's a range, and some people do much better than others. And you can measure something called C-peptide, which is a breakdown product of natural insulin in some people with type 1 diabetes for years and years. So they're probably the lucky ones who can use their onboard insulin to get a much finer level of control. They probably need less insulin as part of their daily regimen as well.
And so with insulin, we have that first phase response, don't we? And then we have the second phase, which is really to control the amount the blood glucose is raised. Is that right? Yeah. So I guess if we don't need to have that so much in that second phase, that's got to be better for us.
Yes, I mean the second phase inevitably happens in the pancreas, and that's why we use something called basal insulin. So with type 1, the current way of managing type 1, whether you use a pump or a pen, is to set a basal insulin rate which covers that pulsatile nature of insulin release, which is used to cover the hormones that naturally raise glucose, glucagon, adrenaline, cortisol, etc. So the idea of a basal rate of infusion, either through a pump or a pen, long-acting insulin, or a pump of short-acting insulin set to a basal rate of infusion, is to control those background functions of the body which will naturally raise glucose. So you'll need a minimum amount of insulin for that all the time. Yeah. And of course, glucose is necessary for certain parts of the brain, and it's also necessary for the red blood cells, which cannot use any other fuel but glucose. So it's we need glucose, but fortunately our bodies can make it for us, so we don't need to consume it as a food.
Well, I think that's something that we need to clear up, because, you know, we hear, you know, the brain has to run on glucose, the red blood cells, probably a few other things. And so we think that that means we have to ingest it, but we don't. So,
Yeah.
you know, perhaps we should start off with what a ketogenic diet is, and how that helps a type 1 diabetic, and then we can dive into some of these other questions.
Okay. So with type 1 diabetes, the people who live longest and do best inject the smallest volumes of insulin. There's something which was published in 2003, all that time ago, of something called the golden cohort, which is people with type 1 diabetes who live more than 50 years. And they had a look at those to think, well, that's amazing how they're doing it. Their level of glucose control wasn't brilliant. It wasn't right down in the 30s or the 5.5–6%. It was 6–6.5%. It was good, but it wasn't fantastic. They had lots of high density lipoprotein, so clearly their cholesterol, so their lipid circuit was functioning really, really well. But they were also using about half the volume of insulin that the other people who didn't live so long were taking. So that begs the question, or it's tantalizing, isn't it, to think, well, if you can actually try to get down on your volumes of insulin, it's probably physiologically good for you. And the other reason it's physiologically good is that when you inject into the skin, the insulin doesn't behave in the same way as when it's producing insulin naturally. So all the time in type 1 diabetes, especially around food and after a meal, you need about twice as much insulin in your skin, in your periphery, if you like, as your body will naturally make. So type 1s, if we're consuming food all the time, will need about twice as much insulin as someone who doesn't have type 1. So instantly that makes it attractive for us to cut down on the dietary stimulus for insulin, so you can use less of it. So the main dietary stimulus for insulin by far and away is glucose, which is obviously derived from carbohydrates. So the idea of the ketogenic diet is to cut down the volume of carbohydrate as much as you possibly can. So you cut down the amount of insulin you're taking. And that will obviously cut down the insulin volumes that you're taking, and you know, the concentration of insulin in your body will be less. So for me, that's an attractive thing to try to achieve. The other main source of glucose, apart from the hormonal stimulus for glucose, which is adrenaline, cortisol, growth hormone, and all that, and glucagon, which acts through glucagon, is of course protein in the diet. And protein in excess will break down into glucose, and that eventually go into fat. And protein, when you're on a ketogenic diet, will raise the blood glucose. So you have to start allowing for that. But conventionally, we allow for carbohydrates, and then we inject insulin to manage the amount of carbohydrates that we've got in the diet. So the big difference really between a keto diet and a high carbohydrate diet is the carbohydrate intake. And you can go where you like on that spectrum. You know, you can have 1 gram less than the average, or if you're going to go into fat burning mode where you're serious about reducing your insulin volumes, you go right down to minimizing the carbs as much as you possibly can, and that'll take you down to 20–30 grams. Some people do well on 50 grams, and that will enable people to be burning fat most of the time. So burning fat produces ketone bodies, so people will be in a ketogenic state most of the time.
And what would you think about a ketovore, carnivore ketogenic diet combination? Do you think that would be too much protein, or do you think that could be well managed?
I bounce up and down around protein. I mean, some people say that if you're on a carnivore diet, you're getting a lot of fat and you get moderate amounts of protein. But I think it depends how active you are, really. I think if you're rested up like we are now and we eat a big protein meal, well, most of that protein will not be needed because we're not needing it for muscle growth. Our cell repair is taking place, that probably takes place more at night than in the daytime. So most of the protein we probably won't need if we're sort of matured adults that aren't in a growing phase and aren't bodybuilding or exercising, where we we probably need to put on more muscle bulk. So, we bounce around, don't we, between 0.75 and 2 grams per kilogram of ideal body weight. And some people and people who are in a growth phase of their life should have unrestricted protein. But I think people get used to what they need. So I've gone back from being a higher protein back to being higher fat, although I do know people who are going the other way onto higher protein. It just depends how your particular body can manage it. But if I'm in an active phase where I'm physically active most of the day, I think I can take more protein than if I'm not. It's perfectly valid to do a carnivore diet if you want to do a keto diet for type 1. That's what people want to do.
Yeah.
Yeah.
And I think one of the queries or questions about very high fat diets is the nutrient density of the diet as well. So we have to make sure that we're still getting adequate nutrition. So not only those amino acids, but all those vitamins and minerals that we need as well. And so I think where good quality sources of protein can help ensure.
I think that's right. Absolutely. Yeah. I think we tend to think of fatty cuts of meat as obviously muscle meat with fat around it. And of course, offal, the kidneys, the liver, are extremely good sources of many nutrients. The liver's got more vitamin C than an apple, for example, and we tend not to think of it as a source of vitamin C.
Yeah. No, that's a really good point, and I'm glad you brought that up. So, we talk a lot, we all know a lot about the dangers of having high blood sugar, but high insulin is associated with all the chronic diseases as well, isn't it? And so that's another good reason for trying to keep control of that insulin.
Well, that's why I feel that the keto diet is the most logical diet that gives you the metabolic advantage in type 1 over the conventional type of diet. And that is because we naturally have to inject more insulin because it's peripheral insulin, isn't it? It's not what you call portal or central insulin. So we'll always have higher levels of insulin, certainly in our peripheral bloodstream. And it makes so much sense to me to keep those levels down because, as you say, it's associated with many other metabolic diseases. And of course, if you have type 1 long enough and you keep having constant daily hyperinsulinemia due to the fact you're injecting more insulin than you technically need. So if you have a high carb diet, you've got to inject so much insulin, you're probably stacking up your concentration of insulin compared with someone without diabetes multiple fold. So if you're in a hyperinsulinemic state, having too much insulin every single day for 25 years, it's inevitable that that's going to cause problems because insulin is a fat storage hormone amongst other things. And if you can't control your blood sugar very well, of course, that you can have the effect of the high blood glucose and of course the inflammatory effect of the high chronic insulin levels as well. So it just makes sense to me to reduce your insulin volumes while reducing your carbohydrate intake. Because
we do see a lot of type 1 diabetics end up being double diabetics. So they have type 2 diabetes as well. And I think a lot of them are quite surprised about that. They don't really understand why that happens.
Yeah, well, you see it, don't you? Because the weight creeps up all the time in people with type 1. The majority of type 1s, their weight creeps up. And that is because the insulin's storing the fat for them.
Yeah.
So, that's something that's not often talked about in the race to get a good HbA1c or good blood sugar control, which is very, very difficult indeed.
So with blood sugar control, I mean, this is another question that I have. How stable do we want it? I know we want a good stable HbA1c, which is at that sort of 10 to 12 week measurement. But what about on a daily basis? How much should our blood sugar be fluctuating? And is that a bad thing? Should it go up a bit after a meal and then drop down? Or should we be trying to aim for like a fairly steady state?
We all aim for physiological steady state, the same as people with no diabetes. But that's a big ask because of the way insulin's delivered into the system. So we all produce nice flat traces for our Twitter audiences. But we all know that in reality, we do get traces which we don't publish, if you see what I mean.
Yeah.
And going up to, 9 and 10 is probably what a lot of us do after a meal, but we rarely drop into the hypo areas. So, but if you balance it well, you don't have to do that. And if I'm in a really good phase for months, I can get a physiological flat trace where I'm in the normal range for most of the time. But when you're more sedentary in the winter months, eating too much, probably boredom, whatever, life alters for us all the time, doesn't it? Females who are menstruating, a period will cause huge amount of insulin resistance, which not a lot of people talk about, and that increases their insulin requirements and makes their blood glucose control more difficult. So I think you should aim for physiological levels between 4 and 7. And I think throughout the night, you should be aiming for 4 to 5 most of the night if you can. But in practice, most people will end up a little bit higher than that. But the majority of people on a keto diet can achieve 90% of the time in range between 4 and 10 without too much effort. But I think it's a big ask to control the spike after a big meal. So, especially if you're on a 2 meal a day strategy, which I tend to adopt. So some people prefer to not worry about fasting in order to get physiologically better control. But we're all so different.
Yeah.
In the UK, there are 400,000 people with type 1 diabetes, and I always say there are 400,000 ways of managing it. I speak to some good friends who are keto or whatever they're doing. One of them insists on having breakfast, and I say, well, why do you want breakfast? Well, I want breakfast because it's better for my diabetes and it's rubbish for mine, and people have all sorts of different strategies, and they work their own way, but they work around the principle of a keto diet and try their best to get a physiological control as best they can. And the majority of the time, you do get very good blood HbA1c. I mean, I've not had an HbA1c in the diabetes range in the past 8 years.
No, that's great, isn't it?
Example. And before that, my HbA1c was, I don't know what you use over in New Zealand, but it was 70, which is not good. It's about 8.5%, which is not good.
Yeah, millimoles
per mole. Yeah, so it was about 70, not good. And the normal range is 42. And then I got down to that range, and I expect it to stay there now. So it's remarkable how much easier it is to manage. And statistically, you get 6 times fewer hypos. I mean, I know a lot of doctors worry terribly about, giving any dietary recommendations or any insulin recommendations for their type 1s, because, I've been in that boat as well. You don't know the person necessarily that well. And you say, oh, I'll just add another couple of units or take away a couple of units. And then you go and worry about it. You think, oh my goodness, what if they go hypo and they crash their car or whatever, whatever they're going to do. But in reality, most people with type 1 diabetes do manage quite well, considering the tasks that they're given every day to do. But with the keto, they have 6 times fewer hypos based on evidence base. And that's reliable evidence, really. So that's remarkable. You think that in the UK, our driving regulations, the Driver Vehicle Licensing Authority sets recommendations for people with type 1, and they're quite strict, especially with remote sensing now of your glucose, so anybody can find out where your glucose is at any moment in time. Coupled with Google Maps, they know exactly what's going on with your blood sugar, exactly where you are on the road and how fast you're going. To have 6 times fewer hypos is pretty good evidence for recommending, at least providing information on keto diets for driving. Because,
do hypos occur mostly at night, or is it throughout?
Any time of the day. Some people are more prone to night hypos, definitely, but any time of the day.
And I suppose because you've got that, because you're putting in that insulin, that's stopping your glucagon, that's stopping your cortisol from naturally raising your blood sugar as you need it. So, and that's what is kind of scary for people trying to help others manage their.
Yeah, I mean, the other thing about insulin, of course, is that you've got is insulin on board, haven't you? You've got more insulin than your body would naturally want if you didn't have diabetes, because it's been injected into the skin. And of course, you change in your insulin sensitivity in the first 20 years or more of your diabetes. So, if you go for a run, your insulin sensitivity will improve, for example. If you fast, your insulin sensitivity will improve. So if you've got too much insulin naturally on board, especially if you've had a high carb meal, then go for an unexpected walk, you might suddenly crash into a hypo without much warning at all, because all that insulin on board suddenly decided, hey, I can express myself now because my body is receptive to insulin. And all of a sudden you've got this hypo. Then you have to gobble, then you want to eat the fridge because you feel hypo. Then you go and raid the fridge and eat it, basically. And then your sugar goes back up again. Then what do? Do you put a correction dose of insulin in and start the yo-yo problem happen all the time? So cutting down your insulin volumes is far more advantageous to controlling your blood glucose. You just get smaller errors.
And then the keto diet helps with satiety, so you don't feel like you need to be eating as often either. And you're talking about 2 meals a day, 1 meal a day, some time restricted eating, maybe some intermittent fasting. And I'd love to talk to you about the what was it, 100 miles in 5 days fasted, which sounds absolutely crazy for type 1 diabetic.
Well, that's why we did it, because I woke up one morning and thought, how on earth can I convince these people that the keto diet isn't dangerous? That you do not get diabetic ketoacidosis just because you've got the word keto in the diet that you choose. It's nothing to do with diabetic ketoacidosis at all. Diabetic ketoacidosis is all about insulin management and whether your body's got enough on board. And of course, I'm vulnerable to diabetic ketoacidosis as someone with type 1, but not because of a keto diet. And so part of the reason for doing the 100-mile run in 5 days was to show that you can go into deep ketosis. That's why we chose 5 days. We thought, well, if we go 5 days, we're well past any stage of using up glycogen stores or anything. If you believe in that, they'll have gone ages ago. I'm not sure whether they do disappear, but there's a school of thought that you use your glycogen up in the first 48 hours, and then you're on your own, if you see what I mean. So we thought, well, 5 days will put that beyond absolute doubt. So eating no food at all would definitely put us into ketosis. And going for 5 days, we didn't want to go any more than that, because there does come a point when just physical starvation kicks in, and then you'll have to start scrabbling around for extra sources of sugar, which is probably where you're going to take your protein mass away. So we didn't want to do that. So we chose 100 miles because at the time people were standing up saying, oh, well, you've got 25,000 calories of fat. And I thought, well, you can go all day on that. I thought, well, nobody's actually proven that. We talk about it a lot, but I don't want to produce that as a fact if it's just a theory, and so I thought, well, let's do it. So we chose 25,000 calories. In fact, when I finished, I had 86,000 calories still on board, and I've only got a body mass index of 22, and my body fat mass is 17% or something, which is average. So loads of fat on board. So we thought, well, 5 days would put it beyond complete doubt. Fasting for 5 days would mean that, yes, you can probably safely skip breakfast. And 5 days without food would prove that you do not need sugar for energy, because we wanted to run it. And that's why we wanted to show you do not need sugar for energy. We also showed that, the 2 people with type 1 diabetes that were running this, and there's 6 others, the 2 of us were well trained in fasting, but we did both still need to take insulin. So we showed that, well, you can take insulin, but you actually don't need carbs, because you've got the appropriate amount of insulin on board for your physiological needs.
So your insulin isn't preventing your gluconeogenesis.
Well, it's balancing the gluconeogenesis,
Yeah.
So that's why you need that little bit of insulin. But our volumes went down to very low. But what we were trying to show was, well, yes, you do need insulin, but you don't need carbs. But of course, if you're on a conventional diet, while you're using industrial amounts of carbohydrates, industrial amounts of insulin, you're going to get erratic control all the time. So yes, perhaps you do need carbs if you're injecting insulin, but if you're well controlled and you get down to the physiological basis of why you're keto, so cut down the amount of insulin required, your error rate is so much less. 1 unit of insulin will drop your blood glucose by, it depends whether you're young or old, but on average about 2, and on a child it'll probably drop it by 5 to 10, and in a crusty old person like me it'll probably be 2, or something like that. So if you're only injecting 2 units per meal, well, your maximum drop of blood sugar is going to be 4. It's hardly going to do anything, is it? So if you start for blood glucose as 6 or 7, you're going to drop down to 3 or 2, which is hard. It's a hypo, you have to recover it. But if you're injecting 10 units of insulin, that's going to drop it by 20 or 30. So you've got to eat the carbs to balance that up, obviously. That's why you have the carbs. But if you get it all wrong and your absorption's wrong, or you're accidentally injected into a small arteriole or blood vessel, you're going to get a rapid absorption of insulin, and that's why it's more difficult with higher volumes of insulin, because you don't have that safety built in with small volumes. So it's dead easy. It's dead easy. You should never be worried about us type 1s. If we can manage ourselves. I had a 23-minute annual review, and that's it for another year.
Right. And
so I'm on my own for another rest of the time.
Yeah. How stable you are. So, there's a lot of concern and care about and worry about managing type 1. And, we're seeing the ketogenic diet being used more freely with type 2. And I think we're seeing a change in GPs' feelings and stances on that. Some, starting to increase acceptability about that. But I don't get the feeling that is so acceptable with type 1. And can you talk, because you do a lot of training for health professionals, don't you? So can you talk a little bit about that and how, what you've got on offer, how health professionals can actually learn more about this?
Yeah, so the thing about type 1 diabetes is that every type 1, as I've just told you, gets an annual review and infrequent monitoring if things go wrong, really. So if things are going wrong, you'll obviously be subcontracted out to other professional specialists, not the diabetologists. So if you get heart problems, you go to the cardiologist. If you get eye problems, you go to the ophthalmologist, etc. So in that management phase, you're encouraged obviously to improve your HbA1c, as if that's the only thing that really matters. But of course, the HbA1c is not just driven by dietary sugar. It's driven by a huge number of factors. Whether you're tired, whether you're stressed, whether you're doing much physical activity, whether you're doing no physical activity. There's dozens of factors that affect diabetes daily control. And it does cause, anxiety amongst a lot of people. I mean, fancy being a parent and sending your kid off for their first sleepover, or fancy being a parent who's receiving a child who has type 1 on their first sleepover. It's the same for doctors. We worry about this erratic control of people with type 1 diabetes. And, in my country, type 1 is considered a secondary care speciality. So GPs don't really get that involved. And I think they prefer not to, because of the image of type 1 being arcane. There are lots of hidden rules and things, which there aren't. It is a very, very simple thing to manage. It's just getting the very basics right. So I wrote some courses for healthcare professionals of all levels, a couple of courses. One's a 6-hour course just to give you it straight, open the box, out of the packet, don't need to read the instructions. Let's get started now. Just to understand what people who want to do a ketogenic diet, what their requirements are. And the second is much more in-depth about mental health, about starting a keto diet with somebody who has existing complications, which is a bit of a minefield, about the origins of type 1, about physical activity, rules for driving, etc. So much more comprehensive. But the basics are basic. They really are. And and they're all, keto management is exactly the same as non-keto management of type 1 diabetes. Conventionally, it's fast to get your basal insulin right, so you know that if you don't eat, your sugar will be perfect as best as you can. And once your basal insulin's right, you just count carbohydrates and inject insulin. But because you're eating very few carbohydrates, you don't need to worry too much about injecting a huge amount of insulin. So your error rate is quite low. And that is it. And you know, when type 1s understand it, they actually get quite cross that they didn't get that information earlier, because all of a sudden, for a lot of people, often for the first time in their lives, they feel that I can actually control this condition. And that's how I felt when it happened to me. I felt completely out of control. And then on day one, my first omelette, once I got over the worry that I might have a stroke, and I hadn't actually stroked out by lunchtime, so I thought, I'm okay. All that fat, you know, and you got a flat trace all day. And you think, wow, that's never happened before.
And so
it's revelation.
what sort of symptoms did you have from your poor controlled type 1, Ian?
Well, I was very lucky for the first 20 years. I relied a lot on physical activity. So I thought, well, I'm going to run this. I'm going to run this one out. I thought, well, yes, my sugar control is not brilliant. It was hovering around, for most of my life, it was hovering about 50, 55, that sort of level. And that was actually the guideline target at the time. So that was considered okay. It wasn't brilliant, obviously, looking back. And then I sort of defocused for 2 or 3 years, and just how things go in one's life. And it went up to about 70 odd for 3 years in a row. Wow. And the problems really were not the ones that are talked about. So hypos weren't too bad. You know, they weren't any worse than normal. High blood glucose was much more frequent. So tiredness, brain fog, and then other things crept in. Postural hypotension, feeling dizzy when you stand up. And that was, you know, if you get a patient in your room and you say, well, I need to examine you, stand up. And you stand up and you have to put your head between your legs for 15 seconds while you recover the situation. Otherwise, you're going to faint, you know. And that was happening 5, 6 times a day, you know. Wow. And you know, so not good. And that was obviously autonomic neuropathy kicking in.
Yeah.
And just blurred vision, joint aches and pains were starting to kick in big time. You know, just standing up, you felt really stiff and jointy. You know, you felt like you needed a good stretch all the time. And in a sedentary job, it's quite hard sometimes. You work 12-hour days sitting in the same seat pretty well, and you just get stuck, you know. And then I got a letter saying you've actually now welcome to the world of complications. So I got a letter saying you've got early retinopathy, and that sort of shook me to the core. Really, it was not unexpected. You know, because we're all taught to believe that type 1 is managed decline, and I would actually challenge that now. So but at the time, I thought, yeah, this was the beginning of the end.
You were really on your way to type 2 as well, weren't you? You were really on your way.
Yeah, I think so. Yeah, so it's just a bit grim all round, really. I was only mid-50s. I thought I can do a bit better than this, hopefully, for a while longer. But, you know, people do deteriorate in their 50s, and by the late 60s, early 70s, it's sort of very serious indeed for a lot of people. They've already had the stents fitted, they've already had the laser done, you know, etc. So it's not a very good thing to think about.
Well, let's talk about the fear of fat for a minute, because that's another aspect that turns people off the keto diet, is all the saturated fat, and it's going to clog our arteries, and it's going to have this detrimental effect on our health.
Yeah, well, all of the evidence for saturated fat and all fat in the diet has come from studies in a high carbohydrate environment. All of it. We struggle to get, don't we, evidence for what happens on a high fat diet. And when they've looked at high fat diets, they move around. So you're allowed, what, 15% fat or something in your diet, and they move around the proportion of sat fat and non-sat fat over a period of 3 weeks or so. And it's, oh my God, the cholesterol's gone up, you know. And somehow that says, well, a high saturated fat diet's not good for you. But they always keep the carbohydrate volume the same, carbohydrate amount the same. and about 50%. And if they go lower carbohydrate, you look at these lower carbohydrates, and it always makes a headline, and it goes down to about 35 to 40%. Well, that's
Yeah,
not
I mean, some of them
carbohydrate.
still
So all of the studies on cholesterol have been done in a high carbohydrate environment, which is a fat storage environment.
Mm.
So when fats are moving around the body, they're moving into the tissues to be stored. So where do they wait while they're being stored? Well, they wait in the blood vessels, don't they? Because they can't move out of blood vessels till they get permission to go in to the storage tissue, which is obviously limited. We're all limited in our capacity to do things. Whereas a high fat diet with zero carbs or very few carbs, well, that's a fat burning environment. So you're mobilizing fat to burn it and not store it. So hey presto, you get the results of fat burning. You get a fat burning profile. So your cholesterol may not change, but your HDL goes up and your triglycerides go down, because you're not waiting for all this fat to go into the adipose tissue, or under your chin, or into your eyes, or into fat pads around the eyes, or whatever. The fat is being used, so you wouldn't be producing fat. You wouldn't be using fat in your system at all unless you want to burn it, if you see what I mean. But if you're eating too much fat, and then of course you've got similar problems of storage. So, but if you're getting sufficient calories from your fat and burning it, you don't need to mobilize your fat stores, if you see what I mean. So the lipid argument, it needs a bit more expansion, I think. I think there have been 4 or 5 reviews now talking about sat fat. But it's very difficult to do good reviews about fats, because it's all based on epidemiological questionnaires. Oh, what did you eat last year? Oh, can you remember what you ate 2 years ago? Out of these 67 items, what can you remember how much of that you ate? And of course, I try not to look at those studies, even if they're in favor of low carb diets, because they're so poorly. I don't think you can make much of them, really. It's like looking out the window and saying, well, what do you think the weather was like in the last 6 months in the UK? Well, I don't know. I think we had a warm summer and had an average August, and cold the rest of the winter. But I don't know. I'd have to look it up and think hard about it. And I think just trying to, you have 3 good days, hot days, and you think there's a heat wave coming. And global warming is obviously global climate change or whatever, isn't it? So I'm not that interested really in the fat argument. Having said that, in a high carbohydrate setting, statins do work, and there's no doubt about that. They reduce a person's personal risk by 1.2% if that person takes them over 5 years, and only you can make that value judgment on whether that is a risk worth taking. As a motorcyclist, I find that risk quite small, really, that benefit quite small. But, everyone has to take their own risk judgment on that, and they shouldn't be criticized if they want to take statins because they want to reduce their chance by 1.2%. Who knows what their background beliefs are, But I think in diabetes, you have to put that into context. And when you have type 1 and you're not very well controlled from your blood glucose perspective, as I said before, 70% of people with type 1 are in England and Wales are losing 100 days of life every year as a result of poor control, which stacks up to about 8 years reduction in life expectancy compared with someone who doesn't have diabetes. Well, statins pale into insignificance compared with glucose control. And the best way to control your glucose for the majority of people is to cut your carbs severely. So inevitably, you're going to have to take more fat, but that's going to reduce your risk of heart disease and strokes, etc., by much more than taking a medication. Of course, you could also argue, and I'm sure I would say to patients, well, I don't know what your risk is on a keto diet of having a heart attack or a stroke with type 1 diabetes, but I don't know whether statins will modify that risk because nobody's doing the studies. But statins that are used for a high carbohydrate environment reduce the risk by 1.2% over 5 years, which which is a relative, that's an absolute risk, obviously, but as a relative risk, that stacks up to about 30 or 40%, which is what, of course, people get sold, don't they?
Yeah, but people don't really understand the difference between relative and absolute risk.
No. So I think it's a whole minefield, really, isn't it? And it's just trying to be logical about it, really, and trying to work out what you feel works for you and your risk profile. But I'm not really bothered about sat fats. There's been so many studies now that haven't shown that they're that dangerous, and even with the limitations of the study.
So what are your thoughts about seed oils? Because, you know, there's a lot of concern about, you know, that imbalance between omega-6 and omega-3 and the, you know, sort of pro-inflammatory effects of omega-6 and, you know, especially around age-related macular degeneration and, you know, some of those kinds of conditions.
Yeah, I'm not an expert on seed oils, really, but I avoid them on the basis that a lot of people are saying you shouldn't be taking them.
Yeah.
I haven't studied them that much, apart from what I've heard and what I've looked at, but I haven't actually gone into the studies personally. So I don't have a view on it, apart from the fact that I avoid them based on what they talk about, the ratios of the inflammatory fats within the oils compared to the non-inflammatory type of fats.
And you know, processed foods, I suppose they come into your high, you know, that's where we have that high carb, high seed oil combination. And then, you know, lots of additives in there as well. So I guess the first step is to reduce the processed foods out of the diet.
100%. Get rid of all ultra processed foods as much as you possibly can. Eat real food, locally sourced, unsprayed, if you can. I think that's the best bet for every individual, bearing in mind that, you know, we are all tempted by ultra processed foods at certain times.
So can you give just, you know, a few of your sort of top tips? I think you just did there, you know, get rid of those processed foods. But yeah, just if someone wanted to start trying this, what would be your key points?
Yeah, the first thing is to get control of your blood, of your insulin, to get to know your insulin. It doesn't matter what you're doing, whether you're on a pen or a pump or a closed loop, whatever. You must understand that how the insulin works in your particular body, because everyone's a little bit different. And if you wanted to go keto, you must get your basal level right. So the best way to do that is to miss meals for about 12 hours. So you skip breakfast and go right through to a late lunch, having not eaten after 8 o'clock the night before, sort of thing, and then do the same in the daytime. And try to get your blood glucose as flat as possible on a typical day. So obviously, if you've got flu or something, your sugar's going to go up anyway as a result of the infection, and you're going to need more insulin. But on a normal typical day, which is your average typical day, try to fast at 2 12-hour blocks and just inject your basal insulin only. Hopefully everyone's now got a continuous glucose meter, much easier than finger prick testing, although you would need to test every half an hour, I'd recommend. Find out what your blood glucose is doing and try to stabilize it. So if your blood glucose is going down, despite the fact that you're not eating, clearly you've got too much basal insulin on board. And if your blood glucose is going up and it's a typical day and you're just not about to get flu, or you're not going to have a period or whatever, and then you clearly haven't got enough basal. So once that's perfected, and then you apply the rules that you know, which are count carbohydrates, study keto diets, so you understand what keto diets look like, and a healthy keto diet is, you can have an unhealthy keto diet, but a healthy keto diet, and then count your carbs and inject the insulin to suit. And then you'll need to realize that you have to count protein as well. But first of all, start off just counting your carbs after you get your basal insulin right. Apply exactly the same rules that you would apply if you were on a conventional high carbohydrate type of diet. And then you will find that you have much better control day to day of blood sugar, and you have fewer hypos. And then if you want to, I would suggest that, but this is personal to everyone, that you try to just increase the time between meals, because it just makes glucose much easier to control. So that's a personal preference. Some people, however, find that that is difficult for them, and their blood glucose is better controlled by having smaller amounts more often. And the other thing that I think is not talked about that much, certainly in the type 2 field and definitely in the type 1, is the value of physical activity, pottering about. You don't need to stick your Lycra on and go on a spin class or go and do 100 miles in 5 days with no food. But you have to be mindful of the fact that pottering about activates your glut receptors in your muscles. And it's a great way of hoovering up sugar that might otherwise stay in your bloodstream, because there's a limit to how much your liver can process your excess glucose out of the system. So you've got this whole other mechanism to suck up glucose from the bloodstream, which is called the muscles.
Yeah.
So sitting down now, I'm relying on my liver to sort out my blood glucose. But getting out for a good walk, you don't need to do much. Walking, gardening, just being active, choosing the steps rather than the lift.
Would you suggest that after meals?
Yeah, absolutely. That's a really good way of controlling things.
Yeah. And so if you did that after meals, then you wouldn't need as much insulin to manage any glucose or protein load that you've had in your diet. Yeah,
I think it makes it easier because you're activating a second mechanism. And I think muscle mass is quite useful to grow. So the core exercises, I think the strength training exercises are probably more effective for glucose control than the running type of exercise, the cardiovascular, although I think both have their place, because you're definitely metabolizing faster in both situations. But the more muscle mass you've got, the more GLUT4 receptors you've got, the more you can hoover up more glucose quickly.
And so
I enjoy it.
Yeah, and then what you covered off there was reduce processed foods, start to eat more locally and seasonally and real food, lower carb. And do you have a sort of a carb range? Would you say 10 to 50 grams a day or 30 grams?
I sort of know. I did what's called a keto Kickstarter, which was basically trying to eat as cheaply as absolutely possible in supermarkets, because that's where 75% of food in Britain gets bought. Sorry. And I did 2 weeks shopping, and it just happened to come out to 30 grams of carbs. So I'm about 30 grams of carbs a day.
Right.
You get used to it after a while.
That's split over 2 meals. That's kind of 15 grams per meal, roughly.
Yeah. So that's 1 to 2 units of insulin.
Yeah. And then just add in the exercise. And if you're not a real exercise person, just try and get up on your feet, have a little bit
just
of
be
activity.
active.
Yeah. And what about mindset? What about how do we start, and then how do we sustain? And do you have any thoughts about that? Because I think people want to try things, people are keen to improve their health, but life can get in the way. Stress, emotions, our beliefs and thought patterns can all sort of cause us to drop off the wagon.
Yeah, I think we talked about this a little bit earlier about what range of glucose do you aim for? Well, we always aim for the normal range, but inevitably things get in the way. For a start, I think the majority of people that I know, and I know a few hundred people now that have started keto, they get really enthusiastic. I say, well, if you can try to stick with it for 3 weeks, it depends, of course, if they have complications, and those with complications should seek advice. I mean, they're probably best going 3 to 6 months of adapting to a keto sort of diet. But for people who have no complications, I always say, well, try to stick with it. Learn how to do it. Seek help from your healthcare professional, if only to tell them what you're doing, so they can look it up before you see them next time if they're not sure on what you're doing, and bring them along with you, because they do want to help you. And try to get their support, but do it for about 3 weeks so you get to know what effect it has on your body. And most people, they just get wired up. They feel really alert, and their joint aches and pains disappear. And that's sustained, and they feel often for the first time in their lives that they're in control of their diabetes. Not that they're chasing their sugars all the time, but they can decide when they have high blood glucose, not their body. It's not quite like that, because sometimes you could do exactly the same thing twice the day after the day before, and it's completely different. It's never quite that easy. But yeah, and then that will sustain most people into the methodology. And then, of course, things happen in life. Stress happens, lack of sleep happens, relationships disintegrate, loved ones pass on, and all these things just add to the load. So if you have a good strategy for managing your blood glucose, and I think if it works, you've got something to default to, even if from time to time you will lapse, that you can get it back into control. So I don't think people should worry too much if they defocus, because we all have to defocus from time to time. But it gives you've got the reassurance that you know what to do. Yeah, but yeah, definitely life gets in the way. Absolutely.
And what you just described sounds like great advice for all of us, whether we're a type 1 or not.
Yeah. Yeah, that's right. But this is type 1s. You don't get any airtime.
Yeah.
So I'm grateful to you for giving me airtime.
Hey, well, would you like to share where people can find you, your website, how they can get in touch?
Yeah, thank you. I'm on type1keto.com. So it's type, and then it's the number 1 keto.com, and that's where everything is. There's some general stuff for people who just are curious to know what keto is. It's non-promotional. I'm obviously very enthusiastic about keto diets, but it's providing the information for people so you can make your own choice. You just might not want to do it, and that's entirely great, but you should know about it, and then it's up to you what you do. And that's the basis of the website. It's an information resource, and added to that are professional courses, which people with type 1 can also do. They're accessible because if we've all got the same information, we can share it around, and I think we make more progress that way. I think that's the way. It's a citizen science sort of thing now, isn't it, with the internet? Certainly when you see your specialist for 23 minutes a year, I think you probably get quite expert at it yourself, really. Yeah, so there's 2 courses for healthcare professionals and of all grades. It's a 6-hour one, which is very accessible, just give people the basics, really. And then there's a 20+ hour one. They're fully referenced. I think there's over 200 references that are all up to date in the advanced course, and it's CPD certified for anybody that wants to show that they've done a course, and there can be mentoring arranged with that as well, should people want to have more face-to-face contact, just to consolidate it. And if you've got the knowledge to pass on to people and give them the information, they can then make their own decision. But if you say, it's better to say you don't know about keto rather than say it's dangerous. 50% of clinicians that I did a survey on my website of 140 people who responded, and 50% of clinicians actively discouraged these people from going keto, which they went to do anyway. They did it anyway. But they were actively, and they were on their own, which is such a shame. So they converted themselves, and remarkably few people had complications. But it's not the strategy for the long term. As we get older, we will inevitably start to get things go wrong with our bodies, whether they're type 1 related or not. So it's nice to bring your clinicians on. And I think, if we can educate everyone as to how keto works and inform everyone, I think then it's up to each individual to make that decision for themselves. It's not saying if I become, if I suddenly become the world dictator, you wouldn't want to live in my world, I'll tell you. Everyone's going keto. No, they're not. But everyone should have the chance to know that there are alternatives, especially if they're struggling with a diabetes.
So I encourage anyone listening to this, if you know a type 1 diabetic, please share this. If you are a type 1 diabetic and you want to have a conversation with your specialist or your GP, please share this with them, or, tell them what Dr. Lake has been talking about, get a conversation going, and you can share Dr. Lake's website and information with them. All that will be put in the show notes, so it'll be easy for people to find. And you're also on LinkedIn. I think that's where I tracked you down.
Thank you.
Unsolicited messages. And are you on, do you have a Facebook page? Or
Yeah, I'm just going to crank up a little bit because I've been a bit quiet. I'm trying to promote my sort of courses a little bit, and so I'm going onto Facebook, more Instagram, and I've got a bit of a presence on Twitter, but I'm not really Twitter material. I'm a bit reasonable for Twitter, but some people like it.
But I'd be happy to promote what you're doing on Facebook. So yeah.
Thank you very much.
Thank you so much for your time today. A really worthwhile conversation. I've been wanting to talk about type 1 diabetes for quite a while, and very reassuring for me when I'm talking to clients who have type 1 diabetes as well. So
thank you very much. Thanks for the opportunity. It's been very enjoyable.
Thank you. Well, I hope you all enjoyed that interview with Dr. Lake and found his information really helpful. As we discussed, we'd love for you to share this video with other people that may find it helpful, with other type 1 diabetics, and with your GP and health practitioners. So many thanks for watching. Please subscribe, like, and share. Have a great day.